Hello, Dr. Morris here to continue to talk about the physiology of special senses. And for the rest of this very long lecture, I realized that between the two parts, it's going to be well over 2 hours. But we're going to talk about the special sense of hearing as well as the other sense that is innervated by the eighth cranial nerve, which is the vestibular system that helps us with maintaining balance and posture, and our sense of where we are in space, which is important for us to be able to move around in our environment. So, just kind of a brief summary of the sense of hearing. Sound waves, which are vibrations in the gas molecules in the atmosphere, are collected by the pinna, the outer ear, and then travel through the external auditory canal, striking the tympanic membrane and transferring the energy of the vibrating gas molecules to the tympanic membrane, making it vibrate. The ossicles, the three bones in the middle ear, are attached in sequence. So the first is the malleolus, and the handle of the malleolus is attached to the tympanic membrane. So the malleolus vibrates when the TM vibrates. And then that vibration is transmitted to the incus, which is attached to the malleolus by a ligament. The incus articulates by a ligament with the stapes. And the conformation of the ossicles actually helps to augment the vibration so that the stapes then is able to transmit those sound waves that were traveling initially through air to the fluid in the cochlea, which is the neural organ of hearing. As I said, the way that the ossicles are attached to each other and their conformation increases the force of the vibration, multiplying it by something like 22 times, so that those very subtle vibrations in the air molecules transmitted to the TM are magnified, multiplied by the time they attach, are transmitted to the fluid in the cochlea. But one of the things that's important about this is to realize that anything along that pathway that interferes with the transmission of vibrations interferes with hearing. So, for instance, earwax in the external ear canal keeps those vibrations in air from effectively causing the tympanic membrane to vibrate. If the TM has a hole in it or is otherwise disrupted, it won't vibrate as effectively. If there is fluid, basically snot, in the middle ear, it dampens the vibration of the TM and the ossicles. If there has been trauma to the ossicles so that they're not properly connected to each other, the vibration is not going to be effectively transmitted to the oval window. So anything along that pathway will affect hearing. And that is a physical disruption. There are neural causes of hearing disorders as well as causes having to do with the transmission of the vibration of the sound waves. Here we have an illustration of the anatomy of the ear. So you can think of the pinna as being like that horn in old movies that the deaf old man is holding to try to improve his collection of sound waves. It helps to collect sound waves, which are then transmitted through the external auditory canal. The meatus is actually the hole, it's the opening. The ear canal is a canal that starts in cartilaginous tissue, goes through bony tissue, is lined with skin, with epithelium, and it ends at a bit of skin that is called the tympanic membrane or the eardrum. As I said, the handle of the malleolus is attached to the tympanic membrane, and then the malleolus articulates with the incus, which articulates with the stapes, which is attached to the oval window. And then this is the cochlea, the snail-shaped neural organ. So there are some interesting things about the structure of the ear. I'm going to go back here where we can see these ossicles. There are muscles innervated by facial nerves that control the movement of those muscles. So there's something called the stapedius and the tensor tympani. And when a loud noise is detected greater than 70 decibels, the tympanic membrane tenses because those muscles contract, which maintains the positions of the ossicles and keeps them from being damaged by very loud noises. And that's called the acoustic reflex. It's a protective reflex that stabilizes the ossicles in the face of very loud noises to keep them from vibrating so much that they are disrupted. Let's talk a little bit about the cochlea, that snail-shaped organ of the inner ear, a neural organ. It basically consists of 3 tubes containing fluid that are coiled up side by side. The 3 tubes are called the scala vestibuli, the scala media, and the scala tympani. The scala vestibuli and the scala media are separated by a membrane that's called Reissner's membrane or the vestibular membrane. The scala media and the scala tympani are separated by a membrane called the basilar membrane. The actual neural organ is called the organ of Corti, and it lies on the basilar membrane within the scala media, and it is roofed by something called the tectorial membrane. So here's a diagram showing a cross-section of one turn of the snail. Okay, we have 3 tubes, the scala vestibuli, the scala media, and the scala tympani. We have Reissner's membrane between the scala vestibuli and the scala media, which is also called the cochlear duct. And then we have this neural organ on the basilar membrane within the scala media or the cochlear duct, and it has cells that are sensory receptors that are sending axons out into the 8th cranial nerve. Let's look at a little bit more detail. Here's a cross section again of that single turn of the cochlea cochlea with its 3 tubes. One thing that I will come back to just to notice in these tubes is that the fluid in the scala vestibuli and scala tympani is actually continuous, and the content of that fluid is similar because they join up at the tip, and the fluid in the cochlear duct or the scala media is different. Here we have a cross-section of a coil, of the whole coiled thing with multiple turns of the coil. So, if you think of the cochlea as those 3 tubes then just coiled up together, at the very tip, the scala tympani and the scala vestibuli are continuous, and that tip is called the helicotrema. And the way that we detect differences in pitch is that the basilar membrane is stiff near the oval window and less stiff as it nears the helicotrema. And near the oval window, where the basilar membrane is stiff, high high frequency vibrations cause it to vibrate. Think about this like think about guitar strings or strings on a stringed instrument. The tighter they are, the stiffer they are, and the higher frequency they vibrate at. It's the less tense, less stiff strings that vibrate at lower frequencies. So when the stapes vibrates as a result of a received sound wave, it sends a wave of vibration down the basilar membrane through the cochlea and towards the tip of the cochlea, although of course it's coiled up, and the tip is called the helicotrema. It's fast at the beginning, it slows, and when a frequency hits the part of the membrane that is of the stiffness that causes to resonate with that sound frequency, the wave dies, and the vibration of that portion of the cochlea basically sends signals to the brain that help it to identify the frequency of the sound. Okay, so again, here we have our three coiled tubes. The two outside tubes are continuous at the helicotrema, also called the apex. The central tube, the scala media or the cochlear duct, is between them. The basilar membrane runs in the cochlear duct or scala media, and it is very stiff at the beginning by the oval window and much less stiff at the apex. And as sound waves move through, or as vibrations from the sound waves move through this fluid, they cause the basilar membrane to vibrate maximally at the point on the basilar membrane that's tuned, that is a stiffness that's going to resonate at that frequency. And once it causes maximal vibration, the wave dies out. It doesn't go a lot further. So here's a high frequency wave vibrating near the base. Here's a low frequency wave with maximal vibration at the apex. So the organ of Corti, which is, as I said, the neural organ, has two kinds of receptors, and the receptors are called hair cells. They have cilia that vibrate, and the inner hair cells are most of the hair cells that synapse with the 8th cranial nerve sensory fibers. And the cell body of these fibers is in something called the spiral ganglion, which is within the cochlea near the basilar membrane. There are also outer hair cells, and there are more outer hair cells, but they don't have as many synapses with the 8th cranial nerve sensory fibers. So again, we have our cochlea with the three tubes continuous at the apex. The central tube, scala media, cochlea duct, contains the organ of Corti with something called the tectorial membrane sitting on top of those hair cells. And here I'm illustrating something I mentioned briefly earlier, which is that the fluid in the outer ducts, the scala tympani and the scala vestibuli is the same, and they are continuous, those two tubes, and it is called perilymph. And the fluid in the cochlear duct or scala media is of different composition and is called endolymph. I did mention that there are cilia on the hair cells of the organ of Corti, and they are displaced when the basilar membrane vibrates, so they move up and down when the membrane vibrates. And what happens is that so these hair cells are sitting on the organ of Corti and topped with the tectorial membrane. So when the basilar membrane of the organ of Corti vibrates, these hair cells push up and down on the tectorial membrane, which cause mechanically gated ion channels to open, allowing the movement of ions that triggers an action potential. So endolymph, which is the fluid in the scala media in the cochlear duct, is high in potassium and low in sodium, so it's very similar to intracellular fluid. And the fluid in the scala vestibuli and the scala tympani is perilymph, and it is high in sodium and low in potassium, like extracellular fluid. Okay, and you can see that these are actually kind of not that far off from the concentrations of fluid in the extracellular compartment and the intracellular compartment. So perilymph high in sodium and low in potassium, endolymph high in potassium, low in sodium. Chloride similar because chloride is the cation for both sodium and potassium in this fluid. So here we have the endolymph in the scala media. We have the basilar membrane with the hair cells and the tectorial membrane on top of it. When these hair cells are vibrating, channels open, allowing an efflux of sodium into the neural cells and triggering action potentials, and an influx of sodium triggering action potentials that travel to the ganglion cells. So again, this has to do with a potential, a membrane potential between the endolymph and the interior of the hair cell. And it's a big potential because the potential on the outside in the endolymph is about positive 80, and the potential on the interior of the hair cell is about minus 70. Now, I want to talk a little bit about how we define the measurement of sound and the scale that we use. So the difference in intensity between a soft whisper and, say, a loud noise like a gunshot can be 1,000,000 times. And so we use a logarithmic scale. And the unit of sound intensity is called a bell, B-E-L, and sound levels are expressed in 10 bells is a decibel, but we can go down to a tenth of a bell as a unit. Now, if the action potentials are generated in the cochlea and transmitted to ganglion cells, then just like with eyeballs, there are pathways that are afferent pathways carrying information from the cochlea to the brain. So here we have the cochlea on either side, and they are transmitting information directly to something called the cochlear nucleus and something called the superior olive. And while that information is transmitted to the cochlear nucleus on the ipsilateral side, all cochlear information is also transmitted to the contralateral superior olive. So it's transmitted to the ipsilateral cochlear nucleus and superior olive, and it's transmitted to the contralateral superior olive, so that we have information from both cochlea being transmitted then to other nuclei within the brain, the inferior colliculus, and then the medial geniculate body. And where do you think that is? That's in the thalamus, which is the relay station for sensory information, where it again synapses, and from the thalamus, the axons run to the auditory cortex, here shown in the temporal lobe of the brain on either side. And so that's the diagram. That's a more detailed diagram showing the cochlea sending information to the ipsilateral cochlear nucleus, to the ipsilateral and contralateral olives, and then to the inferior colliculus, to the medial geniculate body in the thalamus, and then from there sending out axons to the auditory cortex in the temporal lobe, where hearing is processed and detected. So there's bilateral transmission. There's a contralateral predominance, as there is in many senses. There are some collaterals that synapse in the reticular formation, which is a part of the brain that has a lot to do with alertness. And when the reticular formation is activated during sleep, you wake up. So this is why a sound will wake you up at night, because of these collaterals that synapse in the reticular formation. And we don't understand if you look at the visual cortex, the information that is collected in the retina is pretty directly mapped into the visual cortex. There are different kinds of maps along the way of the auditory pathways, and we know that sound is analyzed in a number of different maps, and we don't entirely understand what they do. But we do know that the primary area of the auditory cortex is in what we call Brodmann's areas 41 and 42, and then there's a secondary auditory cortex called area 22, and here's a picture of that. So this neuroscientist named Brodmann defined areas on the gyri of the cortex and numbered them. And in the temporal cortex, the auditory cortex is 41, 42. That's primary auditory cortex. Secondary auditory cortex is 22. You don't have to remember the names. Remember, it's the temporal lobe. Let's see if you remember what this structure is called. That's the central sulcus. It divides this lobe, which is the frontal lobe, from this lobe, which is the parietal lobe. Okay, this is the Sylvian fissure, which separates the temporal lobe from the frontal and parietal lobes. The area here defined as 4 in front of this central sulcus is the primary motor cortex. The areas 3, 1, and 2 are the sensory cortex, 3 being primary. Okay, and then you have motor association areas, sensory association areas, and lots of other things going on. So what happens if something happens to destroy part of the auditory cortex? For instance, somebody's in a motorcycle wreck and their temporal lobe gets somewhat damaged. It doesn't eliminate the ability to hear, but it makes it very difficult to localize sounds. Also, if the lesion is in the secondary auditory cortex, that area 22, it keeps you from being able to understand the meaning of sounds. And there are strokes. Whoops, let's go back here. There are strokes that affect this area of the temporal cortex that result in an inability to understand spoken language, the meaning of sounds, and result in something called a receptive aphasia, where while the person is hearing sounds, they are unable to interpret and understand them. You give this person instructions and they may be able to speak and say, I don't understand, because they can't analyze the sounds that they're hearing. And this slide is just talking a little bit about how we localize sound, and I don't think I would ask you a question. I know I wouldn't ask you a question about this, but there are subdivisions in the superior olivary nucleus. You remember that the superior olivary nucleus gets information from both the contralateral and ipsilateral cochlea. And the difference in sound intensity that's transmitted from the two ears to these subdivisions allows you to localize sound by detecting the differences in intensity from the two ears and also the difference in time that the sound arrived to the two ears. And obviously this is in very small fractions of a second, but your brain is able to interpret those very small differences in intensity to the two ears and in the time of arrival to two ears to let you know what direction to look when you hear a dog bark, for instance. So let's move on to the vestibular system, which is the part of the inner ear that allows us to know where our body is in space. It consists of a balance organ with 3 ducts or tubes that are oriented in 3 different directions, and we call these the semicircular canals or semicircular ducts. One of them is oriented vertically in a sagittal position. One of them is oriented vertically in a frontal position, and one of them is located or oriented horizontally. And we call them the anterior, the posterior, and the lateral semicircular canals. The fluid within these canals moves when we move. And there are hair cells in the canals that detect the movement of that fluid. There are also 2 organs that we call otolith organs, the saccule and the utricle, that have little calcium crystals that are deflected with movement, and again send attached to hair cells, which send signals, and all of the signals that are generated within the semicircular canals and within the otolith organs are transmitted through the eighth cranial nerve, which is the same cranial nerve that transmits the sense of hearing. So there are sensory hair cells with cilia, and they're capped by a gelatinous crest. So there's the crista ampullaris, and then this kind of gelatin substance that's overlying the whole structure. That's called the cupula. And within the canal is endolymph. If you move it, the movement of the endolymph deflects these hair cells, and if they move in one direction they depolarize, if they move in the other direction they repolarize. So again, we have mechanically gated ion channels that lead to the depolarization. In the utricle and saccule, we have these structures that they're very tiny, and the macule lies in the horizontal plane in the utricle and on a vertical plane in the saccule. They're covered with a gelatinous layer with little crystals, calcium carbonate crystals in them, called statoconia. And movement deflects those crystals, causing signals to be sent that detect linear acceleration but not velocity. So these help you know when you're accelerating. There are cilia on the hair cells, and again, they move to open ion channels, very much like the hair cells in the cochlea do. And the direction of the hair cells allows your brain to recognize how your head is moving, or as your head is moving, and to detect both acceleration from those calcium carbonate crystals in the utricle and saccule, and a little bit about velocity and direction of movement from the semicircular canals. Now, there are a ton of reflexes that are associated with the vestibular nerve and the balance organ. When you suddenly move your head, there are receptors that are triggered that send messages to the vestibular nucleus and to the lateral vestibular spinal tract, and your eyeballs move because your impulse is to maintain a stable image on your retina. So when you move your head, you're going to get movement of the eyeballs as well. And in fact, there are reflexes that are used to detect whether a person is brain dead or not. If those reflexes are intact, something called doll's eye movements. When you move the head, the eyes move appropriately, whereas if you are brain dead and that reflex is absent, when you move the head, the eyes just stay in the same position and the eye muscles don't cause that movement. In addition, there are proprioceptors in the muscles and joints of the neck that provide input to the same nuclei, to the vestibular nuclei, and you have some input from the visual system. And all those three things together, the information from the vestibular organ, the information from proprioceptors in particularly the neck, and information from the visual system, all of them together allow you to maintain your balance and your sense of self in space. If the vestibular system is damaged, you are still able to maintain balance if you have input from proprioceptors and vision. And this is the basis for a physical exam test we call the Romberg test. If you have somebody to stand um, with their eyes open and they're balanced and they're maintaining their balance, and then you have them close their eyes. If they have one of two issues, either the vestibular system is damaged um, or the proprioceptors aren't working, so some sensory neuropathies, they can't maintain balance when they take away the visual input. You need two inputs. If you have vision and good vestibular function, you can maintain balance even if your proprioceptors don't work. If you have good proprioceptors and your visual inputs are normal, you can maintain balance with a poor vestibular system. But if you take out two, you can't maintain balance. So somebody with their eyes closed with a faulty vestibular system is going to fall over. And that's the basis of this test called the Romberg test. They will lose their balance, and generally they won't fall over. They'll open their eyes. So here we have the pathways, which there is the vestibular nucleus. Remember that it is getting input not only from the vestibular organ, which is sending information to the vestibular ganglion and then through the eighth cranial nerve to the vestibular nucleus, but it's also getting information from proprioceptors through a couple of tracts, specifically the spino-vestibular tract. It's also sending information through the vestibulospinal tract, and it's also getting some information from vision. There are a lot of fibers from the special senses that go to other places than the thalamus. But then that information, and here again you can see there's information going to the ocular motor nucleus and the trochlear motor nucleus and the abducens motor nucleus. So these are three cranial nerve nuclei in the brain stem that innervate the cranial nerves 3, 4, and 6, oculomotor, trochlear, and abducens. Okay. Information is getting sent to the vestibular area of the temporal lobe. There's processing taking place in the thalamus and the posterior ventral nucleus of the thalamus. So there are a lot of connections with these pathways. I think one of the things that you need to recognize as a pattern whenever we're talking about senses is that there is always going to be a synapse with neurons in the thalamus, which is the relay station that then sends axons to the cortex. Okay, and so this is just a little flow chart showing your pathways for balance and physical orientation with input from vestibular receptors, from visual receptors, and from somatic receptors, proprioceptors, sensing position, muscle tension in the joints, muscles, and tendons. That information is all going to the vestibular nuclear complex in the brain, to the cerebellum, and some of it to reticular nuclei in the brain. There is motor output to the eyeballs, governing extraocular motions through cranial nerves 3, 4, and 6, and to the muscles of the body through spinal motor control through predominantly cranial nerve 11, cause for neck movements and vestibulospinal tract. So all of this works together to keep your head, eyes oriented in light of changes in position. And again, it takes two inputs to maintain balance, and that's how the Romberg test works. So let me step back and see if we can just do a Romberg test. So to do a Romberg test, you have your patient stand up, put their feet close together but not touching. You can either have the arms at the side or have them facing up, but for just the Romberg, at the side is fine, and have them close their eyes. And try this for yourself, and you notice you wobble a little bit because you've lost the visual input, so your input is from proprioceptors and vestibular system. If you were experiencing a vestibular problem, say a viral infection had affected your vestibular system, causing something called labyrinthitis, you might feel a sensation of spinning that's called vertigo. And when you closed your eyes, you would fall over or you'd open your eyes. You would not be able to maintain your balance. Suppose you had severe diabetic neuropathy affecting your proprioceptors and the neural pathways that carry that information. Again, without the proprioceptor input, you wouldn't be able to maintain your balance with your eyes closed, even if your vestibular system was working perfectly. And that's the end of this lecture. I hope you're able to absorb it.